Good evening, everyone, and welcome. My name is Christine Kennedy, and on behalf of my colleagues in the Office of Alumni Engagement, I'd like to thank you for joining us for our second virtual talk in our exploration series. It's nice to see many people who tuned in last week for our talk on zombies who are joining us again. This talk is part of this series, the exploration series, where each Wednesday this month, we are bringing you different and interesting talks to pique your curiosity in the world around you. Tonight, we are welcoming McMaster graduate and medical doctor, Dr. Blair Bigham, who is going to talk to us about the contents of his book, Death Interrupted: How Modern Medicine is Complicating the Way We Die. Before I introduce Blair, I'd like to take this opportunity to acknowledge that the land on which this webinar is taking place here at McMaster is on the traditional territory of the Haudenosaunee and Anishinaabe nations. The territory was the subject of the Dish with One Spoon Wamp Belt Covenant, an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peacefully share and care for the resources around the Great Lakes. Just a reminder, as always, this webinar is being recorded and you will get a link with the recording in an email later this evening. If you have any questions for Blair, please feel free to type it in the Q&A section. And just a reminder, 10 lucky viewers will be contacted probably around 8:30 this evening with the opportunity to claim Dr. Bigham's book. So we're giving those away. So make sure you stay on for the whole event so that we will pick one of your names afterwards and we'll email you. So now it is my pleasure to introduce our speaker for the evening, Dr. Blair Bigham. Blair is a graduate of McMaster. He graduated from our medical school in 2015, and he is an award-winning journalist, scientist, and physician who trained in emergency and critical care medicine at both McMaster and Stanford Universities. He was a global journalism fellow at the Munk School of Global Affairs and associate scientist at St. Michael's Hospital in Toronto. His work has appeared in newspapers, magazines, newscasts, podcasts, and medical journals. Currently, he is the co-host of the Canadian Medical Association Journal podcast, which occurs bi-weekly, and he is the deputy editor of healthydebate.ca. He is currently an assistant professor at the Dalla Lana School of Public Health, where he studies public trust and science communication. Thank you so much, Blair, for joining us. To all of those who pre-submitted questions, thank you so much. We're going to get to some of those at the end, and I think some of the questions will be answered in Blair's presentation. But Blair, I'll hand it over to you, and I look forward to hearing your presentation. Thank you.
No problem. Thank you for the introduction, Christine. I'm just going to go ahead and share my screen. So tonight I am going to chat with you for about 30 minutes about a part of my life that is fairly complex. And that is something that I face every time that I go to work in the intensive care unit. And I want to start by talking about this molecule here. This is adenosine triphosphate. I think about adenosine triphosphate all the time. I think about it before I fall asleep. I think about it as soon as I wake up. I probably even dream about adenosine triphosphate. And the reason for that is because adenosine triphosphate is life. It is everything in your body. It is like gasoline in your car. It is like electricity for your light bulbs. If you don't have adenosine triphosphate in your body, you're not going to be able to make the energy that you use every moment of your life. For most of my life, I have been solely focused on making sure everyone around me has adequate levels of adenosine triphosphate, whether that was as a lifeguard or a paramedic racing through the streets with lights and sirens, or later on in life when I became an emergency doctor and then an ICU doctor. When we think about adenosine triphosphate, if we gathered up all those molecules in your body right now, it would weigh about as much as an egg. But every day, your body will consume an entire reindeer's weight, 150 kilograms of adenosine triphosphate. How does it do that? How do you go from an egg to a reindeer every 24 hours? Well, if you went to medical school or nursing school, you're probably quite terrified right now. This is the chemical equation that everyone has to memorize in school that identifies how we make that energy. And we undergo this chemical equation 170 septillion times a day. And if this chemical equation stops functioning, even for a few minutes, then you're dead. Let me ask you, when is the perfect time to die? Most people don't have a great answer for this. They usually avert their eyes. They definitely don't put up their hand. So I'll toss you an easier one. When is the worst time to die? Most people I talk to have a sense of this. They tell me they never want to die by drowning. They tell me they never want to die alone. Everyone has a worst time to die. And this would be mine. Stuck in a hospital, attached to tubes and wires, too sick to appreciate the people around me. This is not how I want to die. But this is something I subject people to over and over again when I go to work. And I do so with good intentions. I do so because technology can save your life. But sometimes technology can't. There's an interesting tension in the job that I do, where about half of my work is resuscitating people. It's trying to save their life. And the other half is palliating people. It's recognizing that their life is coming to an end, and that my role is to bring some comfort and dignity in those moments. But knowing which side of this tension to fall on in any given opportunity is extremely difficult. This led me to ask the question, is technology complicating the way we die? I decided to explore this because I was actually losing sleep over it. I had patients who I had hooked up to machines. I had promised that I would try to save their life. I was in a situation where I didn't think I could anymore. We don't have to go too far back in history to a time when this challenge simply didn't exist. If we go back about 70 years, people would just get sick and they'd either get better or they'd get worse. If they got worse, people would gather round, people from the community would swing by, rumors would spread that someone's life was nearing an end. You would die in your own bed, not a hospital bed or a nursing home. And in doing so, you would model what death looks like. Other people in your family would see it happen. And so death was more familiar. It was more acceptable not too long ago. Things started to change. If we look at the late 1800s, we have the story of Igor Semmelweis, who was an obstetrician who noticed that women were often dying of fever illnesses after giving birth. Now, eventually, he realized that if he put chlorine on his hands between visiting patients, they would get fevers and they would die much, much less often. He didn't really understand why this was the case. Germ theory was only in its infancy. But regardless, hygiene started to become more and more popular. Eventually, people understood the importance of hand washing. And there were other things happening in society around the same time in the late 1800s as the Industrial Revolution was taking off, where we began to just become a cleaner civilization. We started to have sewers and fresh drinking water. We started to have latrines. We started to have drainage systems. It was a healthier world, and people were dying a little less often. In 1929, Andrew Fleming, seen here, discovered penicillin. Penicillin, an antibiotic that would go on to drastically reduce the deaths soldiers experienced in World War II combat compared to World War I combat. We had hygiene, we had antibiotics. We were moving towards a world where people didn't really die of infections as often as they used to. And then came the 1950s and the polio epidemic. The polio virus caused an infection that would paralyze your diaphragm. This meant that for about 2 weeks, you would be unable to breathe adequately. These giant iron lungs were created to draw pressure through your mouth and into your lungs, the way your diaphragm would had it not been attacked by polio, until such time that polio let go and moved on and allowed people to breathe again. This was really the first time technology was used on a massive scale to try to save people's lives. It would continue over the next decade in the 50s, where giant iron lungs were turned into small, portable, positive pressure ventilators, like the green box you see, smaller than a shoebox there on the screen. In the late 50s and 60s, we had various wars where we learned the value of advanced care in the front lines. We had medics, we had helicopters. Rather than having to retreat a soldier for 2 or 3 days to get them to a field hospital, we were now able to bring the field hospital to them. Mortality rates in war theaters continued to decline. And when all of those soldiers and army medics came back, they needed jobs. And at the same time, the automobile was taking off. Seatbelts, not so much. We had an epidemic of road trauma. And the United States government decided, well, we have all of these human resources and expertise. We have new knowledge that bringing healthcare to the victim can improve their odds. And so EMS was born, Emergency Medical Services. We had ambulances now across America and Canada. And other technologies like this defibrillator held by Frank Pantridge, which used to be the size of a washing machine, was also being miniaturized into something that was portable. We now had the small technology and the means to bring it to patients. And this was really the birth of intensive care. And that is when we started to experience a gray zone. So I want to take a quick time out here and go back and tell you about another story that was happening in the 50s and 60s. And that was the advent and perfecting of organ transplant. This here is Louis Roshansky. You can see the bandage on his chest, and that's because the man he's shaking hands with, Christian Bernard from Groote Hospital in Cape Town, had just implanted a donor's heart into his chest. This was the first successful heart transplant just over 50 years ago, and it made front page news around the world. At the same time, people were talking about this woman, Denise Dorval, who had donated her heart to Louis Roshansky after being involved in a motor vehicle collision. There's a little bit of debate around the circumstances of Denise's demise. The idea of brain death was in its infancy back then. There weren't really rules or guidelines about who could donate a heart for transplant. It had never been done before. And so there's some conjecture about just what state Denise's body was in when her heart was plucked out of her chest. She may have been brain dead, although it's not clearly documented. She was certainly brain injured, but her circumstances back then would probably not fly today. And so we now had a need to define death. Now, one definition, which is when your heart stops, you're dead, is fairly well accepted. It's based on this idea that without your blood flowing, your brain and all of your other cells are going to die within a few minutes. But at the same time, we struggled to define brain death. Generally speaking, it's agreed that you need both an irreversible loss of consciousness and an inability to breathe. Without the ability to breathe, you will not have any oxygen in your lungs. Your heart will beat for a few minutes until it too suffers from a lack of oxygen, and then it too will stop. The challenge to actually define brain death has been half a century of struggle There have been a number of government reports in a number of different places around the world. There's been president commissions, there's been major guidelines published. But to emphasize just how tricky this has been, I'll give you an example that comes out of Japan. Months after Dr. Bernard had done his first heart transplant, a surgeon named Dr. Wado had tried to do one as well in Japan. He was successful. Well, Dr. Bernard was being celebrated. Dr. Wado was being arrested for murder. And for about 30 years, organ transplant in Japan was taboo. It wasn't done. Drastic differences in how organ transplant in defining death made its way around the world. And just last year, we redefined brain death again here in Canada. Small little adjustments, but the definitions do change. They change from jurisdiction to jurisdiction in year over year. And so we still haven't quite gotten this perfected. Okay, so let's unpause. We've had a couple of things happen. We've had a remarkable improvement in lifespan, allowing people to live longer because of improvements in hygiene and the development of antibiotics. We have created machines that can avert death, either by breathing into your lungs, providing you with advanced medications, dialyzing toxins out of your blood when your kidneys fail. And even when death does occur, we've created structures where organ donation can follow to perhaps save a different life. And this could be the end of the talk. This is when we say, fantastic, we have been able to create this amazing specialty of critical care using amazing technology and pharmaceuticals. We are pulling people back from the brink, and it is a very cool space in medicine to work in. But really, the development of critical care over the last 50 years has only been the start of a very long journey. I wonder if we have become too good at delaying death. I can keep your heart beating. I can keep blood flowing to various organs in your body. But that doesn't necessarily mean that I can get you liberated from machines, free of an ICU, discharged from a hospital, living a life that you would consider acceptable. And so often when we are faced with this challenge where our promise of bringing you back using various machines has failed, we then transition from resuscitate to palliate, and we talk about pulling the plug on technology, not using machines to prolong life, and instead focusing on comfort. And the challenges of knowing when to flip that switch, when to go from resuscitate to palliate, led me down this path where I ended up exploring various cases that led me to think that this is so complicated. I want to write a book on it. I want to get really deep into the weeds. And that's what's led me to see you all tonight, is having the opportunity to tell you about what I found in this really interesting exploration of this question that could affect any of us one day. When do we flip the switch from resuscitate to palliate? I can tell you that in my clinical practice, there's not always agreement amongst physicians, amongst nurses, amongst family members. Sometimes it can get pretty messy. Sometimes we just don't know. I'll give you a quick little preview of what I learned during writing my book. I talked to a historian. It's actually a historian of death at the University of Georgia. And he doesn't think this phenomenon of trying to figure out if we should resuscitate or palliate is very new, is a very old phenomenon. He thinks this is quite new. Again, if we go back 70, 80 years when there were no machines, there were no choices to make. Your body would just be unsupportable when it was sick. And if you were going to die, there was really no say in the matter. It's in the last 50 years or so that we've seen technology enable people to stay alive on machines. And that has made it tricky. At the same time, historically speaking, many more people are dying in facilities like hospitals and nursing homes, as opposed to dying at home. Even with palliative care and hospice care, many people die in a hospital. One of the things that I hear frequently is that there are religious prerogatives around whether or not technology should or should not be used to support somebody's life. But when you talk to religious leaders across the world, these rules don't actually exist. But people have perceptions that either you cannot use technology in certain circumstances or that you must use technology in certain circumstances. But none of the major religions have a hard and fast rule. And so this is another area that's very interesting because often we'll have families say, oh, we would like to leave all decisions up to a creator and not make any decisions on our own. Well, other families find reassurance in their belief in a creator and say, let's stop using all these machines. I think it's time to let our loved one go to God. I can't predict what one family will say about a deeply held conviction in terms of whether or not this will help them accept that death is near, or whether it will embolden them to reject the certainty of death. I spoke to a number of sociologists in writing this book. The sociologists find this question fairly easy to answer. They look at the rise of social media and the way people have access to these algorithms through their phone, through their computers, that sort of reflect themselves back at them. It's like you're always looking in a mirror. You're kind of in an echo chamber. And in doing that, people seem to be developing a little bit of an ego where they subconsciously seem to think that, man, other people are going to die, but I'm not going to die. And so they take this sort of approach of, no, I think we'll just keep going, despite what all the evidence, despite what all the medical advice may be. I think we're going to be able to get through this. And this is a new phenomenon where people are moving away from accepting expertise and advice and towards sort of having a more individualistic approach to the way they view the world. I spoke to ethicists, which interestingly, many ethicists would tell me many different approaches to this problem based on their jurisdiction, because ethicists rely heavily on legal precedent when they work through frameworks to help families come to terms with a critical illness or a high risk of mortality in circumstances. And so an ethicist in New York City told me something very different from an ethicist in California, who told me something very different from an ethicist in Toronto. And so I found that very interesting that the ethicist didn't have a clear way out of this, other than to emphasize that there are frameworks, there are ways that you can approach these difficult conversations and difficult decisions. And sometimes these difficult arguments that come up between family members or between physicians or between a healthcare team and a patient's loved ones. Sometimes these cases do end up in court. There are a number of cases that I can think of just in the last few years where the question of whether or not someone should be allowed to die or allowed to remain on life support have ended up in front of a judge. Often these are very drawn out. They are not resolved swiftly. They can take years. And normally It's the wrong place for a conversation about something so full of humanity. I have not seen a courtroom case, and I've been to a couple now where I feel at all good about sitting in that courtroom watching these arguments fly back and forth. I think if we end up in court, nobody's happy. The family's not happy. The physicians aren't happy. The system's not happy. And the patient continues to be in limbo. Lastly, I spoke to an old timer, a physician who had been around in practice for 55 years, Ron Stewart. He actually just passed away last month. And Ron told me that the pendulum has swung quite a bit since he became a physician. When he became a physician, physicians were able to just say, I don't think we can help here. I don't think we can make a difference. I don't think your outcome is going to be worth the struggle you're about to go through. And physicians could just not offer certain technologies. That is probably not the right approach. We know that there's a lot of bias that goes into those offers and those discussions. But at the same time, Ron Stewart felt maybe the pendulum had swung a little bit too far away from physicians, where we tend to be inclined nowadays to offer a menu of items and let people pick what they would want, even if the utility of those offerings isn't clear. In some ways, perhaps we've given too much choice to families. And some families want choice, but they also want guidance. They want help in narrowing down their choices and coming up with a plan. And in some ways, I think physicians have swung too far to the patient autonomy side, where we're not even willing to give that guidance or those recommendations or that advice. And quite often, that can leave families feeling full of guilt and uncertainty. So at the end of writing this book, I had, as a scientist and a doctor nerd might try to do, come up with an equation to help me explain all of this. And what I came up with was that technology, which is required as a multiplier there, without it, you simply couldn't even have this conversation because people would just die, is sort of being obfuscated by two phenomena. The first is resuscitation glorification. This is where people out in society think that medical science can do more for them than it actually can. Or perhaps for medical professionals who are maybe a little too enthusiastic to offer surgery, to offer organ transplant, to offer machines, to offer medications, to offer chemotherapy to people with maybe too much of a rose-tinted lens. And when we add this excitement about what might be possible to the fear that comes around death in modern society, to a death denialism, we end up with this death dilemma that has caused me so much anguish at times. Now, there's always an elephant in the room, and in this circumstance, that would be around prognosis. A lot of the time people say, oh, well, we need to find ways to de-escalate all of these machines from people. But that assumes that I know that the machines are not going to work. I certainly didn't know that when I applied them to somebody. I might have thought it, but I didn't know. And over time, I've learned that we're not that great at predicting who will respond well to therapy and who won't. And so it's all well and good to say, oh, we have people attached to machines who should be allowed to die naturally to have some peace. But I wouldn't want to rob someone of the chance of recovery by saying, this person's too far gone. These machines will never work. because if I don't apply machines in that circumstance, it will become a self-fulfilling prophecy. And so the art of prognosis is where the ongoing struggle will continue. But to bring us back to some of the learnings from my book, where does that leave us in having conversations about the end of life when death is off limits, when families don't even want to discuss it, when having a goals of care conversation is a non-starter? That gets extremely tricky. At the end of the day, what I've learned in all of my exploration is that families are out there rolling the dice. If you say there's a 1% chance of survival, a lot of people are going to go for it because humans are conditioned to keep living. We have a very strong will to live. And if the other 99% is death or disability, sometimes people are willing to risk that. Meanwhile, physicians, we're kind of playing a chess game. We're looking at your lactate level and your creatinine level and your CT scan, and we're trying to piece together the chemistry of your body to see if we can get you to pull through. It's a very different language. I'm talking about adenosine triphosphate, trying to keep you alive. And you're thinking about the potential to lose somebody that you love. But life, of course, is about much more than just adenosine triphosphate. It is about much more than chemical reactions and blood pressure and heart rate and your body temperature and your oxygen saturation. It is about all of the experiences that make you who you are. And so doctors are sitting there having one conversation, a scientific conversation, while families are having a conversation about a threatened humanity, about a loss of somebody who they have so many memories of. And this is why sometimes we get into this struggle. But what I've observed is that over time, these two separate tracks, the emotional and the scientific, can merge. It takes a lot of time, it takes a lot of effort, and most importantly, it takes a lot of trust. But that is trust that you can develop if you put the time into building a relationship with the families of the people that you serve and the patients that you serve. And you can get to a shared path forward, which might not be the one you would choose every time, but hopefully it's one that is fully informed and fully human. A few months after my book came out, I got to experience these challenging decision makings from the other side of the spectrum when my father was diagnosed with metastatic pancreatic cancer and ended up admitted to Sunnybrook Hospital. And it was through medical technology and a surgery and medication that my dad was able to be discharged from the hospital just in time to officiate my wedding. And if you had asked me 2 years ago, when would you bring someone with metastatic pancreatic cancer to the ICU? I probably would have laughed at you and said never. But sometimes people with terrible prognoses do benefit from short courses of intensive medical therapy. That gave us an amazing wedding day and 5 more months with my dad before he passed away. And if you squint, you can see the NG tube coming out of his nose. And he, of course, arrived in a taxi and a hospital gown. And so the Toronto Zoo, where we got married, was kind enough to dress him up in a zookeeper outfit. So this is the type of experience that we can give people through critical care. We don't want anyone to die too early. But we also have to acknowledge that sometimes life support fails. And when we don't move forward with flipping the switch from resuscitate to palliate, we can end up in a situation where people die too late. And finding the balance between these two goals here will consume, I presume, most of my effort throughout my career. Thank you very much for coming out tonight and for listening. I'm excited about the conversation we're about to have.
Thank you, Blair. I'm sorry to hear about the loss of your father, but congratulations on your nuptials, your
Thank
recent
you.
nuptials. So we have lots of questions, as I mentioned, pre-submitted, but I kind of want to ask something. You talked about court cases and these drawn out court cases. So, as a physician, sort of preemptively, would you recommend people start having these very tough, difficult conversations before you get hit by the bus, like just around the dinner table, like bringing up, oh, well, if something was to happen to me, this is what I would like. And I wonder,
Absolutely.
does that not happen? Because as you mentioned, we have this fear of death.
It's an awkward conversation to sit around and say, "Hey, mom, when you kick the bucket, what do you want me to do?" It's not something that we do easily. It's quite uncomfortable. And I actually, while writing this book, had not had that own conversation with my parents. Because I kept meaning to, but it's a weird conversation. It's one though that if you have it, should the need arise, having had that conversation will make decision making so much easier most of the time. Because you can say, "Oh, remember when we had that conversation and so said they would always want, or they would never want, or they couldn't imagine, or don't you dare let them do X, Y, and Z." If we've expressed those feelings, then our loved ones can act on them. They can share them. They can ask for advice. A lot of the time people say, are they going to live or die? And I say, well, they'll probably live, but they're going to have limitations. And people say, oh, what limitations? And that's an opportunity to say, well, tell me about what was important to them. And you'll hear things about how they were very proud and they were very independent. And once when they broke their ankle and had to be in a wheelchair, they just couldn't handle people doting on them. You can start to elicit people's values from those conversations, and that can help me provide guidance. So if you say this person must be a marathon runner, I can often say, well, I mean, I can tell you that'll never happen. But if you say they'd be perfectly happy watching Netflix and hockey games during hockey season, okay, that might be an achievable outcome. And if they're okay with that, then I might be able to get them there. So I think the more conversation you have around this, the easier it is for people to help express your wishes when you're in a situation where you're unable to speak.
Wonderful. Okay, thank you. That sort of leads me to a number of questions we had about DNRs, do not resuscitates. I think there's a lot of nuances with those. Do you want to talk a little bit about DNRs, maybe how conversations can happen around family members, especially as people get older and chances of having, strokes or heart attacks or these, situations that can really impair your quality of life if you're able to overcome those.
Yeah. A do not resuscitate order for me is very vague a lot of the time. People will say, "Oh, she's a DNR," or "Oh, she doesn't want to be a DNR." So, okay, well, what exactly does that mean? For some people, that means that they would never want any machines applied to them. They would never want anything invasive. For other people, it means you can do everything to me except one or two things. Having a DNR is invaluable. Having a power of attorney who can communicate your DNR wishes is invaluable. But I do have to say, a DNR is not the only part of the solution here. So there's been a lot of studies where they've sort of incentivized people to have a DNR filled out, even when they're 30 or 40. And I can tell you, when you're 30 or 40, you might have a different view on what ableism means to you than when you're 60 or 70. And it's also very hard to imagine the context in which you end up in an ICU. For example, if you're an 86-year-old and you have a single lobe pneumonia, it might make sense to put you on a ventilator for 4 or 5 days. If you're 86 years old and you have a urinary tract infection and you require 48 hours of a vasopressor in the ICU, you just might need a little bit of time and antibiotics and you'll get better and off you go. Now, if you're 40 and you've had a devastating brain injury, I don't have the science to make you better. If you're 40 and you have a metastatic testicular cancer or metastatic breast cancer that has failed 3 lines of therapy, I probably don't have a lot to offer you in the intensive care unit. And so I think when people talk about a DNR as a solution to this problem, it's just part of the solution because the context in which you might require critical care can change. But starting to think about it, starting to think about, would I want to be on machines? Would I want to be on machines for a long time? If I had to be in hospital for 6 months, is that something I would want? What if I wasn't able to be strong or independent or feed myself or speak afterwards? Those types of questions can really help people express what they would want should push come to shove.
Okay, well, thank you. Thank you for that. I see we have questions coming in. Before we get to those ones, so thank you, everyone. Please keep feeding those in. I do want to take some interesting questions that we discussed that we wanted to talk about that were pre-submitted. And the first one is, why are doctors unwilling to talk about end of life with family members? Why are they unable to recognize that letting someone die without pain is more humane than forcing them to live past their best due date?
So that's a very blunt way of asking a very common question, which is, are we being too optimistic? Should we just be saying no? And I think that doctors are partially to blame for this, along with everyone in society who often comes in with the mentality of, I want more, I want more, I want more. And a lot of the time doctors say, okay, if that's what you want, like we can do that. But the messaging and the nuance around whether or not it's appropriate can sometimes be missing. And I think that medicine is built this way for a reason. We're built to err on the side of saving somebody's life. And so I almost never judge a team for maybe over treating a patient when they first arrive in hospital, maybe in the emergency department, or they've just crashed through the front door. And no, go for it. We don't have enough information. We don't know how things are going to go yet. Let's see if we can save your life. But over time, it may become clear that saving your life is just not going to happen. And that's where it can be very difficult to have people recognize that, we've done our effort here. It's not working. Perhaps it's time to flip the switch and go from resuscitate to palliate. That can be much more difficult. And yes, sometimes doctors aren't always good at communicating, things are not going well. But also sometimes families are not ready to hear that things are not going well. And it can be surprising when you speak to both a physician and a family member who think that they've been communicating clearly, and you realize, oh, you guys are not on the same page. And that's a really fascinating phenomenon.
Mm-hmm. And obviously difficult, right? Difficult to navigate.
Very.
So the second question that was quite interesting why that was pre-submitted. So why is it that Western medicine is determined to prolong life, even if the quality of life is going to decline? Why are we reluctant to allow death to naturally happen without interventions?
This is a societal shift. I think Western medicine has responded to that societal shift, but it has also, in a way, driven it. And what I mean by that is, as technology became better, we were compelled to use it. But we also sort of started marketing it. Like we sold it as like, hey, look at what we're capable of. And if you look at any medical drama in the 90s or 2000s or all the way up till now, the medical dramas greatly overrepresent the ability of these machines to save people's life. And so society sort of got used to it in the movies, on TV. Machines are going to save your life. You get hit by a car, you get sick, you get cancer, you get an infection, you're going to be fine. At the same time, as we were sort of emboldened by the possibilities of medicine, people were living longer and chronic disease rates were going up. You don't tend to see a lot of chronic disease in the TV shows because it doesn't make for very sexy television. But most of what I see in the hospital is chronic disease. People have had that disease for 20 years, 25 years, 30 years, and they are used to beating it. Ah, yeah, the last time I was in the hospital, they said I'd never get better, but I did. I hear this all the time. And so we keep exceeding people's expectations sometimes. They keep living longer. We're able to manage symptoms that we never used to be able to manage before. And that's a real testament to medical science and to technology. But it has created this really tricky space where it's hard to know if your next hospitalization is going to be the one you die on, or if you are actually going to bounce back and have another 3 months to play bridge or do whatever it is you want to do with your chronic illness. So, in a way, we've gotten so good at it that people are like, no, I've got one more kick at this. And so it's hard for people to accept when we say, you know, we think this might be the end for you. And you can't blame them because our ability to prognosticate is poor and we get it wrong a lot. The other element to this is that it's inherent in the question you asked, Christine, that at some point we maybe just need to put our foot down and say enough of this. Like we're not going to put you on a dialysis machine. We're not going to put you back on a ventilator. But if you're going to give that authority to a physician, you need to understand the inherent biases and implicit biases that come with making those decisions. And we know that certain equity deserving groups and marginalized groups are offered less life support than other groups. And that should give all of us a little shiver. Like, if we're going to go around and say, stop using all these machines on people, it never works, we'd better be right that it's not going to work. Otherwise, we're depriving someone of a chance of recovery. And that's why I got into this job, was to help people get better. Just so happens that a lot of the time I can't do that. But I don't want to miss out on the opportunities where I can. And that's where the real struggle comes in.
Yes, obviously. Okay, so let's hit some of our questions coming in. Oh gosh, we have a lot here. Okay, so question. Will the average lifespan keep being extended and with less disease by science, medical research, genetic DNA modifications, etc.? Note certain animals now live beyond 200 years. What is the rate? What is the rate? Is this expected or likely to occur? Are there any hard limits? When will we eventually be able to live into our hundreds or thousands of years, maybe forever? Oh gosh, I hope not forever.
I love this question. You know, for a while, human life expectancy was just getting longer and longer and longer and longer. But in the last couple of years, it has not. It has started to contract again. And so we may have found that we are pretty close to having maxed out on what medical science can achieve. But, you know, It's only been 70 years that we've had organ transplant and ventilators. There's new chemotherapeutic agents being invented all the time. Are we going to find a big cure to cancer that's going to extend so many people's lives? Are we going to find societal solutions so that young Black women don't die of hypertensive pregnancy related complications at a rate that is far too high here in Canada? There are so many disparities in our healthcare system where we could definitely fine tune society to achieve incremental gains in life expectancy. There's so many opportunities in scientific discovery where something could come along and help us extend life expectancy. But I think what the last couple of years have taught us is that things are pretty fragile. And all those gains that we had over many, many decades slip back, not only during the pandemic, but afterwards as well. So we need to be on guard to make sure that we're always doing everything we can to have healthy populations. Where's the limit? I don't know. I don't think the sky's the limit, but um, there's definitely ways to improve life expectancy right now. As we do that, though, this question of when is the right time to die could become more and more important. You know, Christine, you said, "Oh, I hope we don't live forever." Like at some point, I've talked to a lot of 90-year-olds who say, "No, I am ready to close out my run here. Like I have had a really good life and I'm getting tired." Um, and so I don't know how long we want to live for, but that will certainly be part of that equation as well.
Yes, absolutely. My parents are in their 80s, and my mother just celebrated her 80th birthday, and I made a joke about where we were going to go for dinner for her 90th, and she said, I mean, and she's in wonderful health, but she said, "Oh my gosh, I hope I'm not 90." Like I think sometimes realistically, as you age, you understand that they're not the same that they were at 70 that they were at 60. And I find it interesting. I can't remember his name. There's that billionaire who's trying to live forever and he has the cryogenic
The cryogenic
chamber.
stuff, yeah.
Yeah, yeah, yeah. And this goes to this question about, well, why do we want to live forever? Because our cells eventually deteriorate, they get old. And so if we live to be 110, I don't think we'll ever like be 110 and still have the body of a 40-year-old. I mean, I might be
Well,
wrong.
I don't know. I think that's the grand question, right? It sounds a little sci-fi that, you can freeze your body or that you can have CRISPR come in and fix all of your genetic flaws. But who knows what the future holds? If you can be 110 and physically fit and running a marathon, I don't know, like maybe you're cool with that. Um, but I know a lot of people who are in their 60s and 70s who don't feel like they're up for a huge fight, and would much rather spend shorter, high quality time at the end of their life than be fussed over with medications and surgeries and hospital visits and clinic visits. And so I think it's a really interesting question of what does the future hold? I don't know, but I know that it don't assume that the progress we've made is going to continue. It is very fragile, and we've seen that over the pandemic and with polarization and misinformation, we have actually seen life expectancy go down. And it'll be interesting to see how much longer we see it go down for before it sort of takes a turn back into the right direction.
Or rebounds. Wonderful. Okay. So, question number two. During your research in your book, did you find there were any cultural factors that created more conversations around death?
Yes, but not in the way I thought. So I think that there's a lot of assumptions around how certain cultures handle death, but I was always surprised by these paradoxes, by how one family of the same faith could make a totally different decision than another family of the same faith or the same culture or the same background. And it kind of made me think, oh, a lot of the time we don't even bother having conversations with certain cultural groups because there's an assumption we won't get anywhere with the conversation. And although there are certainly, broad cultural similarities that you could point to, every family is unique. Every family needs their own time and their own space to process what's going on. And I do believe that every family, regardless of their cultural background, is in it for the right reason. They come to the conversation full of love and hope. And that even if that hope is extinguished, the love doesn't have to be. And we can move forward in the interest of making a loving decision for that person, even when hope starts to dim. And so I would say that there are cultural nuances, certainly, but I don't think there are massive cultural barriers that preclude us from making progress.
Okay, well, thank you. So the question number 3 is asking, can you talk about dying too late? And can you give an example?
Yeah. So many patients come into hospital and end up on machines that uh, can lead to a fairly poor quality of life. So they may not have much consciousness or ability to communicate. They might not be able to speak because perhaps there's a tube between their vocal cords. They might not be able to eat or enjoy flavors or different temperatures. If I couldn't have my morning coffee, oh my goodness, that would be a struggle. Um, and so often the price you pay for being on machines can be quite high. You can lose dignity. You can develop painful bed sores, um, all for very little, if any, appreciable conscious gain. And so that's where we talk about dying too late. So I've had a number of people who die in these beautiful ways. Their family is present, they're able to be conscious, they're pain-free. They celebrate the day of, they have a moment of family togetherness. Those types of really meaningful interactions are often, people are deprived of them when they die slowly on machines. And so I think those are situations where nurses and physicians and respiratory therapists often feel quite a lot of heartache because we've subjected you to these machines and now we have no way of liberating you from them. We can't get them off of you. Um, and yet you're living a pretty miserable existence. And so we don't want that for people. And most patients don't want that for themselves. What I also don't want, though, is for patients to say, no, 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 don't put me on a ventilator because it might not work. It might not, but also it might. So if you say, no, 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 I don't want to be on a ventilator, you're kind of deciding that you're okay dying in the next couple of days. And if your fear of being stuck on machines is so strong that you're willing to peace out early, then we might also be doing you a disservice by not being able to communicate your chances in a more articulate way. And so it is really, really tricky and really sticky. If you would never want to say, for every 100 people who die too late, how many people don't you want to die too early? Like that becomes a really difficult game. But that's almost what we're asking in this conversation, because pitting down the exact moment where healthcare becomes futile and people should just enjoy those conscious moments they have left, that's extremely difficult to do.
Mhm. Again, because it's the ability to forecast, right?
Right, exactly. And so there's always a gamble involved. If we're going to go for it with machines, there's a gamble that you might end up debilitated and stuck on them. There might be a payoff. Maybe you get better. But also, if you decide to forego the machines, you might also be missing out on a chance of recovery. And some people are okay with that because they're so terrified of the alternative. But in a very stressed and overburdened healthcare system, it's not uncommon for doctors to just be like, "Oh, you want to be DNR? Oh, thank goodness." That, our resources are so strained that sometimes I worry that we're, you know, not that we're talking people into resuscitation, but that sometimes we're trying to talk them out of it, even though we don't have that crystal ball.
And maybe a little bit for the wrong reasons.
Yeah, I think the system is under so much strain that I see patients say, "Oh, I don't want to be a bother on you guys. You can make me a DNR," and I'm like, "Whoa, what? Like that's awfully generous of you." But no, like we're here for you. And then I've had overwhelmed teams say, "Oh, we don't have any ICU beds today. Let's go and see if we can make this person not interested in ICU services." And I think that is a sign of the resource strain that this country faces and does a real disservice to people.
Yes, over and over. Okay, how about we have time for one last question? It's a question about advanced care plans. People can prepare advanced care plans in most provinces, and BC has a MOST form, MOST form, to specify the medical care you want. Can you elaborate a little bit on that, Blair?
Yeah, so a lot of advanced care plans or do not resuscitate orders have multiple options. So it allows you to articulate how far you want a healthcare team to go in an effort to save your life. And so sometimes this helps address that challenge of context that I mentioned earlier, where when you need that form, you don't really know the circumstances of what got you there. But those forms allow you to be a little bit more articulate than simply a DNR or no CPR or no intubation or these sort of one-line directives, and instead be more nuanced in requesting what you would be willing to go through. And a power of attorney for medical care, which is a legal document that you can complete with the help of a lawyer in any province or territory, can also be a helpful document. So DNR generally is a bedside conversation that's had between a doctor and a patient. Hey, would you be interested in certain things? Whereas a MOST form, or in Ontario, it's a post form. Those types of documents are more articulate and can be filled out in advance of actually needing to be in a situation where the answer is required immediately. And so many people have those advanced care plans filed at their hospital or ahead of a big surgery or sort of on a routine admission for future reference. But they're not always set in stone. And again, the context is so important because certain technologies work well in some contexts and not well in others. So it's hard to just create that tick box. No, I don't want that technology. I don't want that technology. Because in a certain circumstance, I don't know, maybe you would.
Well, it sounds like it gets very complicated.
It does.
It's a very complicated conversation, situation, but you have provided lots of information that basically I think you've started a conversation, and I think that's what you wanted to do with the book. That was the goal, right? To get people thinking.
Just even if it's a conversation only with yourself, because and these conversations are awkward to have even with the people closest to you. But I think if people just start thinking for themselves, what would the right choice be? If you can communicate that to someone who can help express it when the time comes, you'll be doing yourself a favor because nobody wants to end up tied to machines at the end of their life with no way out.
Absolutely. And especially not surrounded by people, right? If you're surrounded by machines and medical staff, then you don't have time or the
Yeah.
the actual physical ability to be with your loved ones.
Yeah. I've seen a lot of people die alone at 3 o'clock in the morning, and it
It's
just seems like nobody would choose that for themselves.
absolutely,
Yeah.
absolutely. Well, thank you, Blair, for joining us and for bringing into our consciousness, a very difficult topic. As you mentioned, we don't like to talk about death, but it's inevitable, and it's probably something that we should be talking to our loved ones about, and like you said, even thinking about it ourselves. So just to remind everyone that Blair's book is Death Interrupted. It's the sorry, it's on How Modern Medicine is Complicating the Way We Die. So Jessica and I are going to pick 10 lucky winners. We'll send you a quick email to let you know if you would like us to purchase that book for you, and then we'll send it off. We'll order it from Indigo. Just a reminder that next week, this time next week, we are going to be having a talk on the Fibonacci sequence. So November 23rd is National Fibonacci Day for all of you math aficionados out there. And we thought we would do a talk about math because Math is fun. And then the following week, we are doing a talk on AI, and that will be a lunchtime talk at 1 p.m. So thank you, everyone. I hope that you've enjoyed this talk. I hope that it has sort of sparked some ideas and perhaps some conversations that you will have with your friends and your family. And we look forward to seeing you again at one of our webinars. Thank you. Take care, everyone.